So our next speaker is Zahir Soonawalla from Oxford. Zahir is part of another dynamic duo, developing a very excellent robotics program in Oxford. And Zahir works with Mike Silver to get their program to where it is now. So Zahir is going to talk to us about mitigating challenges and ensuring transparency in robotic programs.
Thank you, Ed, and thank you, Jawad. So we started a robotic program in Oxford late in 2021. And we took a slightly different approach from Guildford in that we felt it's better focused to a few surgeons. So 2 out of our 5 surgeons do robotic surgery. So it's Mike and myself. And I wanted to share with you our experience of the Whipple's procedure. We did level 2 cases for about a year. And so at the end of 2022, we felt very pleased that we were really comfortable with the robot, and our experience with liver resections and distal pancreatectomies and gallbladder cancers was going really well. And then 2023 was really the first year of our Whipple's program, and we did about a third of our Whipple's robotically. We were reasonably selective, but with Jawad's help, we were able to get the program up and running reasonably quickly. In the next year, we tried to expand the program, take on a bit more difficult cases, high BMI, larger tumors, and tried to get up to 50% of our Whipple's robotic, and did find that we ran into a few problems. Operative time initially was pretty long, 2.5 to 3 hours more than an open case, and that's come down, and now it's about 1.5 hours more than an open case. Blood loss, significant benefits with robotic surgery. But when we looked at our complications, there was a marked reduction in the robotic group with minor complications, particularly pulmonary and wound complications. But there was some increase in the more serious Clavien-Dindo 3B complications. And that was a bit of a concern for us. So we did an audit of that period, and we saw that there was a definite increase in the incidence of pancreatic leaks. Our open data was 15%. The robotic cohort, 22%. And linked with that, there was a slight increase in delayed gastric emptying. There was a slight increase in returns to theater as well. So it was a bit of a concern for us. Despite that, we were seeing a reduction in mean length of stay, because clearly 80% of patients are still benefiting from the procedure. So we concluded that we were still in the learning curve. We hadn't yet transitioned to beyond the learning curve. We still need to be careful with case selection. There is some compromise with a higher anastomotic leak rate in your learning curve, and we need to be aware of that. And there's a risk of increased returns to theater and possibly some increase in secondary hemorrhage. And we need to be aware of that as well. Many of you will be aware of this paper that came in JAMA some months ago, and it looked at, it was a retrospective study looking at established robotic units, 36 centers, large numbers of cases, and a direct comparison of open and robotic cases. And they were primarily looking at early postoperative outcomes. These were all centers that were well past their learning curve. So in the learning curve, most centers have a higher leak rate, and then it levels off. And these were all centers where their leak rates had leveled off and were as good as their open leak rates. And what they showed was that even though the leak rates were the same in open and robotic cases, the patients who underwent robotic surgery who leaked were more likely to have a clinically relevant second complication. They were more likely to need to return to theatre. They were more likely to have secondary hemorrhage. And our data, we also felt that even though our numbers were very small, we felt we were experiencing this as well. We compared our data to the data from this large series. So the dark blue is our robotic data, the dark green is our open data, the light blue is the international cohort robotic data, and the light green is the international cohort open data. And you can see we have a big difference in pancreatic leak rates in our robotic and open cohort. And our open cohort is actually better than the international open cohort. And we think that's because about 10 to 11 years ago, we started doing a full omental wrap around the pancreatic joint, and we found it reduced clinically significant leaks, and it largely eliminated secondary hemorrhage. And we found it much superior to the falciform ligament. We can't do that robotically, at least not yet. And we don't know if that has an impact. But we also have higher delayed gastric emptying than the international cohort. And you can see in both the international cohort and in our cohort, there is more secondary hemorrhage in the robotic group than in the open group. This does have implications for patient consent. We need to discuss this with our patients and explain it to them. That's what we do. My experience has been that despite not being honest with the patient about this, nearly all the patients still choose robotic if they're offered it. Personally, we would like to investigate the option of doing an omental wrap, and it would be useful to see if anyone else has experience of doing it robotically. I suspect if we look at all our Whipple's outcomes across the UK at the moment, we will be hard pressed to show any cost effectiveness or improved outcomes from robotic surgery. And we need to be aware that units in their learning curve will continue to need support beyond the first 5 proctored cases. Thank you.
Tell them to do it open or robotic.
I would tell them to do it robotic and go to you.
One more question there. Thanks so much for a great talk. I think your point about the complications of the robotic Whipple is a good one. I'm not sure Melissa Hawk is here yet. She's giving a talk after lunch, but basically this year at HPBA, her group and the Pittsburgh group as well showed that their fistula rates of the robotic Whipple were lower than their open Whipple, to your point. But when a fistula happened, the seriousness of that fistula was higher, and what they found was that their bleeding rates were higher.
Yep.
But their bleeding rates were not from the GDA stump. The bleeding rates were from the SMA.
Oh, okay.
And I think one of my thoughts were that I think in an open Whipple, you feel the SMA, right? So you're a little bit further away than you think from the SMA, and you're going up and you leave some tissue on the SMA. But in a robotic Whipple, you can't feel anything. And the way we stay safe, as what Ahmad showed in his video as well, is that you see the adventitia and you go along it with an energy sealer. And I wonder, because of that, we are on the adventitia, it's magnified 9 times, you're a lot closer than you think you are. And we're using an energy device that we tend to bleed more from the SMA when we get a fistula, and which brings you back to your point of an omental wrap, essentially.
Yeah, exactly. The other thing is, I think patients who leak after robotic surgery need to go back to theatre more often, in my experience. Probably they don't form adhesions, the drains don't work as well, and they end up needing good drainage for some reason or the other. And the secondary hemorrhage, I agree. Has anyone used an omental wrap or? Yeah. We used the falciform initially at open, but then found the omental wrap much more effective. So we switched to the omental wrap because it gives a full 360-degree wrap.
But how do you make the?
You make a tongue of usually the left side of the omentum.
360.
And use it, you put it below and take it up
Yeah.
a full 360 and then 2-3 stitches to tack it down. It should be possible. It would be interesting to.
Yeah,
see
I use a pedicle round ligament flap, but I think to that point of the SMA, scalonizing the whole SMA is great for Twitter photos, but maybe we shouldn't be doing it as much and leaving some tissue on it as long as oncologically it's a safe thing to do.
Absolutely. That's a very good point. Thank you.
Great talk, Zahir. Thank you.